My name's Tom Powles. I'm an oncologist in London at Barts Cancer Centre and the Royal Free Hospitals. So KEYNOTE-564 is a big 1,000-patient randomised phase 3 study of intermediate and high-risk clear cell renal cancer. It was a one-to-one randomisation of a year of pembrolizumab or placebo. The initial results came out about a year ago now, and those results showed a significant delay in progression-free survival and a trend towards overall survival with a toxicity profile in line with what we expect from pembrolizumab. There is subsequent to that, and the presentation at the EAU this year, is an updated overall survival and progression-free survival analysis, also a metastasis-free survival analysis and progression-free survival 2 analysis. So lots of new data which essentially supports the original data. So the updated progression-free survival shows a hazard ratio of 0.63. The curves go apart and they stay apart, and those curves look, I think, more impressive than the original curves with further follow-up, and that's really reassuring. The second thing is the survival signal, very immature, relatively few events, but there's still a hazard ratio of about 0.53 in that environment. Now, what does that mean? It just means there's an early trend towards a survival, but that's important when patients are considering whether to have this or not. The progression-free survival 2 is important because that considers not just what the patients had initially, but also whether the placebo group was salvaged with sunitinib. And the PFS2 also favours the pembrolizumab arm. And of course, metastasis-free survival is important because patients die from metastatic disease, not local disease normally. And the metastasis-free survival also favours the pembrolizumab. So in summary, the efficacy signal in these 4 parameters are all pointing in the right direction. The disease-free survival, the initial endpoint, the primary endpoint that we've looked at, is now significant and continues to be significant. And indeed, the most recent update, the curves look really nice. I think they go apart and stay apart. And metastasis-free survival, progression-free survival 2, and overall survival, all essentially trending in the right direction, supporting the fact that this drug has activity. 6% of patients were randomized who had M1-NED. What that means is they had metastatic disease that had been resected, low-risk metastatic disease that had been resected. When you look at the subset analysis, the benefit is clear in that population as well, as you'd expect. However, it's only 6% of patients, and actually when you look in the grand scale of things, it hasn't had a huge influence on the intermediate and the high-risk population. In fact, when you look at the subset analysis, which I showed, it's the intermediate risk patients that make up the vast majority of patients. So these other subsets aren't making a huge difference in the M1-MED. Yes, the benefit is there for pembrolizumab, but actually it's not driving the whole benefit. Overall survival is overall survival, and there are lots of different ways of analysing other endpoints, metastasis-free survival, PFS2. In the end, what are we looking for? We want patients to live longer and feel better. And actually, I think the toxicity profile of these drugs for a year is of concern, and we need to put that into context. But I think that we will, in the end, hit overall survival, and if we do, that will reinforce those original PFS findings. So the reality of the immune profile of these drugs is about 10% of patients probably get significant toxicity. And some of that toxicity is life-changing, ranging from diabetes, thyroid function, can cause other problems, pulmonary fibrosis. And these pictures of toxicity need to be balanced with the benefit of the drug. And I think the toxicity is worthwhile talking to patients about, in fact, essential to talk to patients about. And the translation to quality of life is complicated because I'm not convinced our quality of life tools are perfect for analysing adjuvant pembrolizumab in clear cell renal cancer. So the quality of life data doesn't look hugely different actually to placebo, and for the vast majority of patients they get relatively few side effects, but just the process of coming to hospital every 6 weeks to have an infusion, that's going to affect one's quality of life. I'm not sure if that's up or down. I can imagine some people like coming to hospital and some people don't, but all of these factors are likely to have an effect. So I think there probably is an effect on quality of life, particularly for those 10% that have life-changing toxicity. I'm not sure our tools are perfect, but nevertheless, when you look at the overall picture, for the majority of patients, it doesn't seem to have a huge effect on quality of life. I mean, when one looks into the future, I'm not very good at predicting the future, so that's a good place to start. So whatever I say now has to be taken with a pinch of salt, but we have got other trials coming up, and inevitably Some of those trials are PDL1 inhibitor studies, some are PD1 inhibitor studies, nivolumab, atezolizumab, for example. We haven't seen those data yet. And of course, there's combination data of ipi-nivo, there's durvalumab data, and durvalumab tremelimumab data. So we're going to have actually quite a few different trials. Are all drugs the same? I don't think they are all the same. I think that's important. And are all combinations the same? And obviously not single agent therapy, CTA4, PDL1. I'm really excited about a trial looking at ipilimumab and nivolumab together. I'm excited about the durvalumab and tremelimumab data. I think those two questions are really important. Can we give the combination and improve survival or PFS further? I don't know the answer to the question, but I think it's an important question. The final piece is we're also doing a study which is really new and exciting and was just starting, and that's with a HIF inhibitor, belzutifan, with pembrolizumab versus pembrolizumab alone. So we've moved on to a second generation of trials where pembrolizumab is now the control arm, and we're trying to improve survival further with new exciting drugs in the field. So it's a really exciting area. I think this 564 is the first really positive step in the right direction. I suspect it's not the last step.